Hello, everybody. This is Menopause Taylor bringing you the state of menopause in the world today, and I'm so glad to be joining you all today. I'm Menopause Barbie, your Menopause Taylor, and I teach you all you need to know about menopause and the rest of your life. I've been giving you some broadcasts about healthcare systems, insurance, and doctors, and I'm giving you a bunch of practical information that'll help you manage your menopause your way. But there are some hurdles in managing your menopause your way. And one of the biggest hurdles is that very little in the world of medicine is actually about doing things your way. And more significant than that is the fact that very little in medicine is about you, period. And that's because much of medicine is focused on populations instead of on you. So this broadcast is all about population versus personal medicine. Now, if you're wondering why you need to listen to a podcast on population versus personal medicine, then you really need to listen to this podcast on population versus personal medicine. Because as much as you may think you're getting personalized care when you go to your doctor to discuss your personal situation, wants, and desires, you aren't. The problem is that you don't realize that so much of what goes on between you and your doctor has absolutely nothing to do with you. It has to do with the whole population. So I'm going to teach you how this focus on the population rather than on you affects you personally. And I'll give you some tools for getting the focus back on you. Now, much of what I'm going to teach you comes from my master's in business administration. Mine focused specifically on the healthcare industry. So what you're going to get is a miniature MBA in healthcare. I want to start by discussing the historical basis of healthcare because it will help you understand how things have gotten so impersonal. Way back in the olden days, before there was a medical insurance industry, the medical industry itself was a very simple industry. There weren't many doctors and there weren't many real cures. And doctors practiced medicine independently as solo practitioners. Patients would go to their local doctor, receive the advice and treatments offered by that local doctor, and they would pay the doctor in whatever way they could. Sometimes they gave the doctor live chickens, sometimes they gave him baked goods, sometimes they swapped services. If the patient was a tailor, he might make the doctor suits in exchange for his medical care. Sometimes the doctor received a cash payment. But the medical industry was about helping people. And doctors did whatever they could to help people. Each patient was unique. So the relationship was entirely personal. There was no middleman at all. Then medical insurance came along. Now, at first, medical insurance didn't interfere with the doctor-patient relationship. You and your doctor decided what was best for you, and the insurance company just paid for whatever the doctor charged. With time, insurance started paying only what it considered usual and customary charges for medical service. They would assess payment by populations. So the usual and customary charge was the average charge for a particular treatment by physicians in the same local region. So this was an application of population medicine for purposes of payment only. But notice that the population of focus at the time was the population of doctors, not patients. Usual and customary went by what doctors charged, not by what patients needed or what other patients were getting. The next step was when the insurance industry began dictating what it would pay for. So instead of just limiting how much it would pay, it also limited the services for which it would pay. Now, this may not sound like population medicine to you, but it most definitely is. And that's because the insurance company would pay for the treatments and procedures that were most cost effective for the insurance company. Whenever the focus shifts to what's most cost effective from a business standpoint, you no longer get personalized medicine. Your personal preferences become secondary to what's cheapest for the insurance company. Now, this set the stage for the next level of population medicine, which was cost containment. Cost containment involved finding ways to limit spending on patient care. Well, you know what? There's only one way to limit the cost of patient care, and that is to limit patient care. More precisely, it's a limitation on personalized patient care. And this limitation or cost containment has taken many different forms over the years. In the 1990s, it was in the form of HMOs, or health maintenance organizations. HMOs involved a fixed payment per patient per month. Thereafter, this thrust to contain costs took many other forms, including preferred provider organizations, or PPOs, which was a contract with medical providers in a particular network. There were also patient-centered medical homes, PCMHs, in which treatment was coordinated through a primary care MD to avoid redundancy and trim costs. And there was something called bundling of procedures together, with one price for the entire bundle of services entailed in a single disease diagnosis. Like one price for all your obstetric care from the first visit through the delivery and the postpartum care. As these new models tried to contain costs, they started shifting into terminology that focused on quality of care rather than containment of costs. And then other models started appearing that had names implying better value. One of them was value-based care. This one promised improved quality and better outcomes for patients. Another one was pay for performance. Pay for performance was directed at physicians. They only got paid if a certain percentage of their patient population achieved certain standards. In essence, it shifted accountability for your health outcomes to your physician. So if your blood pressure wasn't controlled, it was your physician's fault. If you didn't follow your diabetes diet, it was your physician's fault. Even though your behavior has a lot to do with your health, it placed all the responsibility on your physician. And if you didn't do your part, the physician wasn't paid. See, most patients have no idea that these models still exist today. Now, the problem with all these models is that they are not focused on your personal quality of care or your personal outcomes. They focus on either the entire community population of patients or on an individual doctor's population of patients. So instead of making sure that you get your mammograms and bone density scans, they focus on making sure that a certain percentage of the entire patient population gets them. They're all about statistics. Statistics always look at the whole population. They are not about you. But in the process, you become more lackadaisical about being on top of your own health care. These models make patients think the quality care measures will keep them healthy, but these quality care measures don't keep them healthy. The next ramification of all this was electronic health records, or EHRs. Everybody is so fascinated with technology. So when the medical industry first started using computers, they were targeted only at billing. But then their use spread to include coding for diagnoses. And next, they were used to chart patient data. You probably remember the first time you went to your doctor's office and the computer was in the room. To those of you who are old enough to recall the days when the doctor looked at you, examined you, interacted with you personally, Suddenly it felt as if the doctor was taking care of the computer instead of taking care of you. Everything was in the computer. Your medical history, your exams, your labs, your diagnoses, their codes, your meds, your billing data, your insurance, everything. And when all that information was in the computer system, it was possible to track everything. Now, this was supposed to improve the quality of your care, but what it improved was the ability to control costs. The different electronic health record systems cannot communicate with each other. It's like Mac and Windows. Their programs are not interchangeable. All this computerized data is great for tracking what's going on a population-wide level, but it's disastrous on the personal patient level. Instead of making it easier for your doctor to do what's best for you, it makes it nearly impossible. For instance, if you want a particular type of HRT for your menopause, the computer may not let your doctor order it if it isn't allowed by your insurance. You may want it, your doctor may want you to have it, but the computer disallows it. So the next development was something called conglomerates. Conglomerates involved mergers of big hospitals and medical industries into even bigger organizations. Now, what does that do? It creates dominance of the market. So instead of having a lot of choice as to where you want to get your medical care or which doctor you go to based on practice style, you discover that they're all part of the same system. Doctors never wanted it this way. But the constant market pressures made it impossible for them to be able to have independent practices. It was merge or perish. And once they had merged or sold their practice to a hospital, they had to follow the rules of the purchasing entity, in addition to following the rules of your insurance company. And that's not all. There's another layer of population medicine that limits your options. Long ago, I gave you a podcast on guidelines. Guidelines are what the medical industry uses to determine when you need a screening test, like a mammogram or bone density scan, or when you need certain kinds of procedures or tests. Guidelines are created by committees of physicians, insurance companies, patients, equipment manufacturers, health associations, and public health authorities. So all these people sit around a table and decide when and how often you should get the test. But it's not based on what's best for you. It's based on what's best for the population. Guidelines are always about population medicine. They are never personalized medicine. So the guideline may say you should get your first bone density test at age 65, but you may be at high risk for osteoporosis and need your first one at age 50. And when you combine what the guideline says with what your insurance will pay and what the pay for performance standards require and with what the electronic health record will allow, there's nothing personalized at all about your medical care. Do you see how far off the mark this can be from what you need as an individual? I get comments every single day from women who have an obvious need for a bone density test, but their doctor doesn't order one. You see, the reason I teach you this stuff is so that you'll realize that the system is all about the population, not about you. You have to take care of you, and I'm giving you the tools with which to do just that. Now, sometimes that will mean that you need to pay for something yourself. Sometimes that will mean that you need to find a new doctor. Sometimes it will mean that you need to ask the doctor to call